Good evening, everybody, and welcome to this evening's Managing Hepatitis B in General Practice webinar. My name is Samantha, and I am your host this evening. Before we jump in, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I would like to introduce our presenter for this evening, Dr. Vicky Shepherd, and our facilitator, Dr. Tim Senior. Vicky is a public health physician who has been working for New South Wales Health since 1999. Vicky's current role is medical advisor for viral hepatitis, and she is working with local health districts and primary care to achieve the targets of the hepatitis B and C strategies. So thank you for joining us, Vicky.
Thank you, Sammy.
And also our facilitator, Tim. So Tim is a GP at Tharawal Aboriginal Corporation in southwestern Sydney. Tim's also an RACGP medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health and a senior lecturer in general practice and Indigenous health at UWS. So welcome, Tim.
Good evening, everyone.
Wonderful. I'll hand over to you now, Tim, to take us through our learning outcomes before we jump over to Vicky.
Thank you very much. So these are the learning outcomes, which is the educational speak for what we're hoping to achieve over the next hour or so. So by the end of this online activity, we all should be able to describe methods to identify our patients with hepatitis B, understand the essential role of general practice in managing chronic hepatitis B, describe contact management for people with hepatitis B, recount the triggers for specialist referral, and access available hepatitis B resources and education tools. So I shall hand on to Vicky to start us off. Thank you very much, Vicky.
Oh, thanks, Tim. Yeah, and good evening, everyone, again. It's great to be here with you and really pleasing that we've got so much interest in this webinar tonight. So first off, why is hepatitis B a health priority? You are online, so you must understand that it is. Now, with our younger people born in Australia, hepatitis B is almost not an issue because since we've had universal vaccination in the past 20 years, people under 20 rarely get hepatitis B in Australia, and usually those that do were born overseas and missed out on vaccination. And we've got a slide about that in a minute. But nevertheless, despite that success of our vaccination, hepatitis B is the most common bloodborne virus in Australia. And it's estimated there's around 250,000 people living with chronic hepatitis B. Now, a decade ago, many of these people were thought to be healthy carriers and given that label. But we're now very well aware of the complications of hepatitis B, which is cirrhosis leading to liver failure, and hepatocellular carcinoma. And those conditions are increasing in Australia, and particularly in parts of New South Wales where there's high immigrant populations. And we'll look at where those countries are and which areas of New South Wales are affected. But the really good news is that effective long-term management of hepatitis B in primary care can reduce the burden from hepatitis B. So in some ways, this is another cancer prevention activity. And, I think that's a useful lens to look at it. So, between 1 in 4 and 1 in 5 people with chronic hepatitis B will die from cirrhosis or hepatocellular carcinoma. So what are we trying to do with hepatitis B? So what our national strategy aims is to diagnose 80% of people living with hepatitis B and have at least half people with chronic hepatitis B engaged in care and increase the proportion of people on antiviral treatment to 20%. Now, so there's obviously some caveats that go into these objectives. There's no, I guess in an ideal world, we would diagnose 100% of people, but that's probably not possible. And we would like to have everyone with hepatitis B engaged in care. That's desirable, but the current target for Australia by 2022 is to have half the people engaged in care. Now, hepatitis B is definitely very different to hepatitis C, where we want to treat everyone with hepatitis C with antivirals. For hepatitis B, it's recognised that only about between 15 to 20% of people will need antivirals at any one time. So that's the target, to get 20% of, that's thought to be a desirable level of antiviral treatment. But how are we doing? So the data I present now is at the end of 2016. Only 62% of people in Australia with hepatitis B were diagnosed. Only 17% were engaged in care, so that's very low, and only 7% were receiving antiviral treatment. And there's not been a lot of change since the end of 2016, very marginal increase in those figures in New South Wales. So before we get into the meat of it, just a recap about hepatitis B. So it's a bloodborne virus transmitted by blood and other body fluids. The most common time of transmission is mother to infant, but it can also be transmitted sexually to other household members, through needles and sharps, and in healthcare. So acute hepatitis B will manifest somewhere between 1 and 6 months after someone's exposed to the virus. It's often asymptomatic, especially in young children and infants, but it can still cause severe liver injury, and rarely it can cause liver failure in adults. But we do rarely encounter acute hepatitis B. But certainly chronic hepatitis B is the condition we're talking about tonight. Now, the most really interesting thing about this is that the likelihood of getting chronic hepatitis B is very much dependent on the age at which someone catches the infection. So because of immature immune system in infants and children under 5, those 90% of infants are unable to clear the infection, so it becomes a chronic infection in the liver. And that compares to someone who catches the infection as an adult, where 90% of adults will clear the infection and only 10% become chronically infected. So this is all very much tied up in the pattern of hepatitis B we now see in Australia. It's also really crucial to understanding it is the distribution of hepatitis B internationally. So the darkest colour are countries where the prevalence of chronic hepatitis B is more than 8%. The medium green countries are between 2 and 7%, and the low prevalence countries are in the grey, where less than 2% of the population have chronic hepatitis B. And so once again, we see that countries where many of our patients are drawn from have either high or intermediate prevalence of hepatitis B. And so the migrants from those countries bring that risk of hepatitis B with them when they come to Australia. I guess the thing that this graph doesn't show, with Australia having a low prevalence, is that our Aboriginal population does have a high prevalence of hepatitis B. Certainly Aboriginal people are older than 20 years of age, and they have a prevalence similar to that in high prevalence countries. And that's something that's found around the world with Indigenous populations, which is, I think, why in Canada, areas where that's mainly inhabited by Indigenous Alaskans, North Americans, are where there's a green band up there affecting Greenland and northern Canada. So this is the notifications in New South Wales, fairly stable, and what I was speaking about before, the pink and the dotted orange line, those are children under 5 and children 5 to 14, almost zero, and pretty much all those cases there are children born overseas or children, very rarely children born to women with chronic hepatitis B whose preventive treatment at birth was unsuccessful. Interestingly, the kind of magenta dotted line is dropping, so that's 15 to 24 years of age. So as the vaccinated cohorts come through, the prevalence in that age group is also decreasing. And we're seeing an increase in the 45 to 64-year-olds, which might be due to increased recognition and better testing, or it might be also related to migration patterns. And then the final thing as far as epidemiology is where the cases are in New South Wales. So here there's a very big distinction between metropolitan and non-metropolitan parts of New South Wales. So Sydney, Western Sydney, Southwestern Sydney, Northern Sydney, and sorry, I've missed one there. The five main metropolitan local health districts, Southeastern Sydney, have relatively high notification rate compared to the non-metropolitan local health districts. And once again, that's about where migrants have come from and the highest proportion of migrants. So I think this then leads us to say who should be tested for hepatitis B. So New South Wales Health would recommend that all patients born in Asia, the Pacific Islands, Africa, the Middle East, Eastern and Southern Europe, South and Central America, and the Caribbean are tested for hepatitis B. And then other patient groups that are important to test are Aboriginal and Torres Strait Islander people, people who've ever injected drugs, men who have sex with men, anyone who's ever been in a prison, people who are hepatitis C or HIV positive, and then patients on renal dialysis, people with abnormal liver function tests of unknown cause, or pregnant women, and anyone who requests to be tested. And just highlighted here with the green asterisks are people who also should have a hepatitis C test as well because of shared risk factors for those infections. And then the final recommendation is that any patients that are planning chemotherapy or immunosuppressive therapy should also be tested for hepatitis B because they're at risk of a severe flare of their infection if they are immunosuppressed. And we just wanted you to know that in the new year, we'll be starting a new campaign that's targeting Chinese, Vietnamese, Arabic, Korean, and sub-Saharan African communities by using, but the sub-Saharan one is in English. The others are in the community language of those groups. And the tagline of this is to increase awareness amongst people born in those high-risk countries that we've already been discussing, that hepatitis B may be asymptomatic, so they should be tested, and to talk to your doctor. So we're hoping that this prompts many people at high risk of hepatitis B to come and ask you for a hepatitis B test. So I'll just pause there. Are there any questions we should get to at the moment, Tim, or I'll push on?
So no, there's one question that I think we're going to be covering later in the presentation anyway. Okay. So unless people type quickly now, we're all good to go. Okay.
All right. So here's where I think Tim's general practice experience is really I really want to draw on that, because it's how do you identify your hepatitis B patients. So I've already said we'd like to know at least 80% of people with hepatitis B, know who they are, and have half of them engaged in treatment. And obviously they have to be diagnosed before they can be engaged in your care. So obviously anyone who asks for a test and they're in one of those risk groups we've discussed should be tested. But the next thing, and I'll ask Tim to comment about this, about how you can use your practice and quality improvement in your practice to find your patients who should be tested and get them in for testing. So Tim, can I ask?
Yes, absolutely. So it's a really important question. So we'll have some people come in and we recognize that they may be in one of those risk groups, but not particularly requesting a test, and we can raise this with them. Many of those risk groups, it can be a little bit difficult because they're not easily coded in our medical record. So some of it may depend on our tacit knowledge of our patients, about their country of birth, or about their history and who they're living with, and whether they've ever used intravenous drugs. And so some of that may be searchable in the patient record for us to do active recalls of people saying, we'd like you to come in for a hepatitis B test. And some of it will be just good history taking, sort of knowing knowing our communities, and that there are communities where, for example, IV drug use may have been maybe prevalent, and so being able to ask that. The next thing would be the way that we actually use our patient record to be able to code, say, country of birth or IV drug use, that we can actually do active recalls of people who are at risk. And I think there are probably examples of some practices who are able to do that, but it's not easily codable in the records. So some of those things are things that you could take back to your practices and have a discussion about, well, who do we know, and how can we identify patients who we should be testing for hepatitis B.
Okay.
We have got a couple of questions coming as well, Vicky, about the people with tattoos, whether we should be testing them routinely.
Yeah, certainly if they're tattoos that are done in home or overseas cultural settings, so the Pacific Islands and parts of Asia, they'll be done without any sterile conditions. Tattoos done in prisons, certainly those are risky tattoos. If people have had tattoos in a tattoo parlor, their standards are usually very good, and it's very rare that people who've gone to a tattoo parlor in Australia or in New South Wales will pick up hepatitis. So I wouldn't routinely test people with tattoo.
And so again, that comes down to our good history taking about, I see, I like your tattoo, but where did you get that done? And sort of just asking a conversation to check whether people are at risk. I got it done on a beach in Thailand as a teenager. They might need testing.
Yeah, and the tattoo in prison is definitely a risk.
Yeah,
definitely.
Absolutely. And people do self-tattoos in prison and tattoo each other. That's a thing.
Yeah.
The other question we've got there about management of hepatitis B positive pregnant women, I think we'll come on to, we'll cover some of that later on.
Come on to that, yeah. And the other question about managing people with chronic Hep B and normal liver function tests, we'll cover all that in a minute. Mm-hmm.
That's right.
All right, so the next thing is, once you've identified the patient that you should be testing, is how to test. So there's 3 tests should be requested. And here we need to understand a little bit about hepatitis B infection. So we should be requesting the surface antigen, which is the obviously the outside of the hepatitis B virus. We should ask for hepatitis B core antibody and hepatitis B surface antibody. So these are looking at different parts of the hepatitis B virus, and these help us interpret whether the patient has infection and whether they're immune, and we'll go through that in a minute. Now, on the form, you write query chronic hepatitis B, and that means that these testing is covered by Medicare if it's done in the context of someone with those risk factors that we've been describing. There was a question about E antigen. That comes later. So the first step, the cheapest step, is determining whether someone has chronic hepatitis B. So these are the 3 tests to request. We'll talk in a minute what we do if they come back positive. So this is the first case study we have, which is about Mahmoud, and he's a 40-year-old, one of your regular patients. And he comes to see you prompted by a campaign in Arabic about needing to get tested for hepatitis. So you review your file notes. Mahmoud was born in Libya and migrated to Australia at 10 years of age, and he's been your patient for 15 years. You don't have any records of ever testing him for hepatitis, and he's not had any abnormal liver function tests during this period. Your records indicate both his parents are deceased, but you don't have a cause of death recorded. And to your knowledge, Mahmoud's a devoted family man and a devout Muslim. So, what should you do? So, explain to Mahmoud that yes, Libya is in a region where hepatitis B is endemic, and due to the risk of him being born there and him having an early childhood infection, it is important that he gets tested. And also recommend that he's tested for hepatitis C and HIV, also because of coming from the Middle East. So what you do is order hepatitis B surface antigen, core antibody, and surface antibody, and write query chronic hepatitis B on the order form. Now, interpreting test results. So here's where by ordering these 3 serology tests in combination, they can tell us about the patient's hepatitis B status. So if all 3 tests are negative, they're susceptible to hepatitis B, they've never been exposed, and if they are at ongoing risk of hepatitis B infection, they should be vaccinated. The next column is someone who's surface antigen negative, but they have their core antibody and their surface antibody. So that tells you that they've had a past infection because they've got a core antibody, but because they've got a surface antibody and their surface antigen is negative, it means that they've cleared their infection. So they're immune to hepatitis B, but there is a risk that they could get a relapse of disease with severe immunosuppression. So that's something to note for the future that, if, for example, they're having to have a transplant or monoclonal antibodies, that you might need to consult a hepatologist about the risk of hepatitis B flare at that time. The next column is immune due to vaccination. So because this person, if they've never experienced the full hepatitis B virus, they've only experienced the vaccine, which is just the surface antigen part of the virus, they're not going to have core antibody. They've just got surface antibody. And of course, they don't have surface antigen. So that person can be reassured that they're immune and they've been immune due to vaccination. So the one we want to focus on tonight is the 4th column, so chronic infection. So these are people with surface antigen and core antibody, and because it's a chronic infection, they haven't yet developed surface antibody. So these are the people we're going to be focusing on tonight and talk about disease staging and monitoring. And then the 5th column is a bit confusing, where there's just a core antibody but no surface antigen or surface antibody. That might be a recent infection, might be a false positive, it could be an occult infection, and that one is a bit more complicated and we won't have time to discuss that tonight, but there may be some clinical context that helps you to interpret it, or you may need to seek specialist advice about those patients. So Mahmoud's tests come back. So he's surface antigen positive and he's core antibody positive. So he has chronic hepatitis B. He has a long-standing infection that hasn't been cleared. He still has surface antigen. So you take a further history. Has he ever had a hepatitis test before? Did he have any surgery in Libya? Has he ever injected drugs? And what did his parents die from? So importantly, you find out that his mother died of liver cancer. His father, unrelated. He's not injected drugs nor had surgery overseas. And to his knowledge, he's not previously been tested. So this starts to add up now. His mother probably had chronic hepatitis B as well, passed it on to him in infancy, probably at birth, and unfortunately she died from the complications of that chronic hepatitis B. So what do you need to do now? So here we're going to talk about the staging of his chronic hepatitis B. So the first thing to do is to assess his disease phase. And to do that, you need to look at his hepatitis E antigen, which is another part of the hepatitis virus that we don't need to test for, only if we know someone has chronic hepatitis B. We need to order a DNA level, so quantitate how much virus he has circulating. We need to look at his liver function tests, his full blood count, his clotting, his alpha-fetoprotein. You need to do a physical examination to look for stigmata of liver failure. A liver ultrasound is indicated, and assess whether he has liver fibrosis using an APRI score, which is using the ALT and its platelet count. And there's an online calculator that you can use to calculate that. So that's assessing his disease phase. The next thing you need to check is if he has any co-infections. So it's really important to check for hepatitis A, C, D, and HIV. Now, hepatitis C, D, and HIV may have been acquired by the same route, but it's also important to know if he has a co-infection with any of these hepatitis viruses, because that can lead to more severe outcomes. And if he's not immune to hepatitis A, then it's really important to vaccinate him, because if he has chronic hepatitis B and catches hepatitis A, that can lead to fulminant hepatic failure. So an important preventive measure to do right up front. And the third thing to do is to assess his contacts. So it's important to arrange for his household and sexual contacts to be screened for hepatitis B. And if they're not immune, to vaccinate them, because they could be at ongoing risk of hepatitis B. So this is covering some of the earlier questions we had, Tim, about assessing disease phase and what to do. So out of those tests that you've just ordered, a virus level or a DNA, the liver function test, ALT, and the E antigen, these are used together to classify chronic hepatitis B into one of 4 immune phases. So the first phase is immune tolerance, where early in the infection there's high levels of circulating virus, but the liver is not impaired, and the person still has the E antigen as well. Then the disease at some stage, and it will vary by individual, move on to an immune clearance phase, when in fact the DNA is coming down, but in the liver there's active response in the liver, so the ALT is raised, and during this period the E antigen starts to disappear, and the anti-E the E antibody starts to arise. So this immune clearance phase is at a time where patients are at high risk of cirrhosis and hepatocellular carcinoma. So people in this phase should be referred for consideration of treatment. Then after patients move through that phase, they move to the immune control phase where the DNA's low, the liver's fine, and they've got E antibody. And those patients can be monitored in general practice. And then the final phase is immune escape phase, where once again the virus becomes active, the liver inflammation starts up, and this phase again needs to be considered for treatment to prevent cirrhosis and hepatocellular carcinoma. So, general practice is crucial to be monitoring the DNA, the liver function tests, and the E antigen and antibody. If patients are in the immune tolerant phase or the immune control phase, they can just continue to be monitored every 6 to 12 months in general practice. They don't need specialist intervention. But once they enter the immune clearance or immune escape phase, then it's really crucial that a specialist consultations happens and the patients are considered for treatment.
Yeah, we've got a few questions. One about the hepatitis V DNA, the viral load. Is that Medicare rebatable in someone who you've done the initial serology testing?
That's right. So for patients that are not on treatment, it's rebatable every 12 months. And for patients who are on treatment every quarter, 4 times a year can be done.
And do people move between the groups? So, for example, if someone's in an immune clearance group and it moves to immune control, then they can shift just to the monitoring phase? Does that happen? That's one of the questions.
Yeah, usually once someone starts on treatment, it's then lifelong. They risk a flare of infection if they do stop, but that's where the hepatologist will give you the best advice about what to do with those patients. But in general, once they start on antivirals, then that's an ongoing treatment.
Yeah, and even if it's just a mildly abnormal LFT, that justifies a referral?
Yeah, well, usually more than double the cutoff, and we've got the cutoffs in some upcoming slides. It varies. That's right, yeah. for men and women. Yeah, and if it's just mildly raised, you might want to get them back in 3 months to see what's happening, because as the graph indicates, it can fluctuate a bit in those immune clearance phases.
Yeah, and do the different phases change the nature of risk to contact of the patient, or we're just doing contact tracing on everyone anyway?
Yes, well, clearly if the DNA is low, then they're going to be at lower risk of transmission. But if you, for example, diagnose someone in immune control phase, they might be at very low risk of transmission then. But if it's been their sexual partner for the past 5 years, maybe they had a higher DNA level earlier. So, yeah, we don't really use the current DNA level or immune phase to look at what kind of contact tracing is necessary. Interestingly, for healthcare workers, so there's been a recent change to the national guidelines, and now even healthcare workers with chronic hepatitis B, provided their viral load is suppressed, they can do surgery or exposure-prone procedures as long as their viral load is fully suppressed. So that's a new thing that came in earlier this year.
Yeah, and we'll talk about the cutoff points for viral loads as well. We'll see some examples of the sort of figures that we see for that shortly. So I was asking about fertility considerations for patients undergoing treatment, and whether they might need to consider having eggs or sperm stored prior to treatment.
No, we'll talk about pregnancy a little bit later on. In fact, we do use antivirals during pregnancy to prevent the risk of transmission. So, in consultation with a hepatologist and an obstetrician, antiviral treatment's not a barrier to pregnancy.
Excellent. That's
All
great.
right.
I think that's all the questions for now.
Okay. All right. So what we've done so far is assess the disease phase and look at co-infections. The other thing we need to think about with patient monitoring, and once again, this is very much something that can occur in general practice, is looking at the patient's risk of hepatocellular carcinoma. So the things that dictate risk of hepatocellular carcinoma are the presence of cirrhosis, which you've assessed initially by your APRI score. And if your APRI score is abnormal, then you would refer for a proper assessment of if cirrhosis was present. Age and race, so in particular Africans from the age of 20 years, Asian males and females from 40 and 50 years, and Aboriginal people from 50 years are at increased risk of hepatocellular carcinoma, irrespective of other contributing factors. And then people with a family history of liver cancer are also at risk. So if your patient has any of these risk factors, they, on top of monitoring their hepatitis B, they need hepatocellular carcinoma surveillance as well. So we need to develop a monitoring plan. So it's depending on the disease phase. Patients in phases 1 and 3 can be monitored in general practice with 6 to 12 monthly viral load and liver function tests. Of course, the viral load can only be funded 12 monthly. And then on top of that, the patients at risk of hepatocellular carcinoma need 6 monthly alpha-fetoprotein and an ultrasound. And then the final and really important thing that should be happening in general practice is education of the patients. Their understanding that this is a lifelong condition and the importance of them coming to see you every 6 to 12 months to have their condition monitored. What their transmission risk is. So I understand a lot of misunderstanding. People, some cultural groups think it can be transmitted by sharing food, for example. So explaining to your patient how it is transmitted and what they need to do to protect others. And then also generally their liver health, so their weight, their alcohol intake, smoking, etc., to minimise the other strains on their liver. And this also includes things like not taking traditional remedies and botanical extracts, etc., because many of those can have liver hepatotoxins in them. Sorry. Okay. All right, and the triggers for specialist referral. So just to summarise it, we've really talked about all these things. But so patients in the immune clearance or immune escape phase. So if the ALT is elevated, and that's more than 30 units per litre in men and more than 19 units per litre in women. If the DNA is also above 2,000, so you recognises that you might get some small fluctuations from alcohol or something. They don't all need referral just because the ALT is up a bit, so in conjunction with a high DNA. Any abnormalities in the ultrasound, high alpha-fetoprotein. If your patient who's got chronic hepatitis B has a need for chemotherapy or immunosuppression. If you find they have a co-infection with hepatitis C or hepatitis D. And for pregnant women, if their viral load is above 200,000 international units per mil, irrespective of what immune phase they're in. So I'll just touch very briefly on the basics of antiviral treatment because that's not the purpose of tonight's webinar, to learn about antiviral treatment, because it is a S100 prescription authority, so you need to do a course to be able to prescribe hepatitis B antivirals. But both entecavir and tenofovir are the first-line treatments in Australia. They're oral, 1 tablet a day, and as we said before, once a patient starts on hepatitis B antivirals, it's usually indefinite, and the exception is that when the antivirals are used during pregnancy to stop transmission, then women will usually be weaned off them postnatally. It's important to emphasise to your patients that once they start on treatment, they shouldn't stop, and if they do, that they risk a flare of acute hepatic failure. And the good thing to know that it's very unusual to develop antiviral resistance, but it's crucial that they do comply with their daily pills once they start on it. And while interferon is no longer the treatment of choice, then your hepatologist may consider it in a select group of patients. We won't delve into that anymore tonight.
We've got a few questions coming through just before we move back onto the case. If patients prefer to be initiated on treatment in phase 1 and 3 in that previous diagram, is that worth doing?
Well, I mean, certainly they could be referred for a consultation, but I believe that unless they were pregnant, most hepatologists wouldn't be recommending treatment in those phases, because once it starts, it's ongoing. But that would have to be discussed with the specialist.
Yeah. If there's no evidence of HCC but chronic Hep B, would patients still need half-yearly AFP and ultrasound?
Yeah, yes, because
They
it
do, yeah.
could develop at any stage, so it's important to monitor that every 6 months.
Absolutely. And someone's asking about the management plan for babies born to mothers with chronic hepatitis B. And there's a whole set of prophylaxis during delivery, isn't there?
Yeah, so women, I'll just briefly touch on that then. So women with chronic hepatitis B, as we said, need a viral load measured and their ALT monitored. If their levels above 200,000 units, they should be referred for treatment. But all women, whether they've got a high viral load or not, their infants should be given hepatitis B immunoglobulin within 12 hours of birth. They should be given hepatitis B vaccine within 12 hours of birth. And then they should receive the full course of hepatitis B vaccine at 6 weeks, 4 months and 6 months of age. And then they should be tested with those 3 tests that we mentioned, surface antibody, surface antigen and core antibody, 3 months after they finish their course, their primary course. And hopefully you demonstrate that they've got immunity to hepatitis B. If they don't have immunity at that age, 9 months plus, they should be referred to a paediatric hepatologist, and there's a service at Children's Hospital Westmead. So that's the basics of infants born to mothers of hepatitis B. Okay, we better move on. Is that right, Tim?
Yep, that's good. Let's move on.
All right, so back to Mahmood. So we get his results back. You get his results back. So he's E antibody positive. His DNA is low, less than 2,000, and his ALT is within the normal range for his age, for men. So he's in the immune control phase. So he's developed E antibody. So his other tests, his full blood count's normal, his clotting's fine, his ultrasound's fine, his alpha fetoprotein is low. You pick up that he's not immune to hepatitis A, but fortunately he doesn't have any co-infection with hepatitis C or hepatitis D. So on that basis, you recommend a course of hepatitis A vaccine, 2 doses, 6 months apart. So you've assessed his immune control phase. You've got a plan there. The next thing is his hepatocellular carcinoma risk. So we've already established that he's got a family history of liver cancer. He's not in one of the racial groups that have a higher risk. His AFP and ultrasound are normal, and his APRI score is less than 1, so we don't think he has cirrhosis. It's a pretty sensitive test for picking up cirrhosis. But because of his he has chronic hepatitis B and he's got a family of hepatocellular carcinoma or liver cancer, he needs to be monitored every 6 months for hepatocellular carcinoma. So you need to educate him that it's crucial to see you every 6 months for his AFP ultrasound and liver function tests, and then get his DNA done every 12 months. He should avoid alcohol, smoking, and herbal medications, maintain a healthy diet, healthy weight, and explain to him about how hepatitis B is transmitted. So the main risk for him is sexual partners. So his family comes in. His wife Salima, she's 38 years old, born in Oman, 2 children, otherwise well, doesn't recall being vaccinated for hepatitis B. Her parents are both well and alive, and she's normal physical examination. Their 2 children are born in Australia, and you check the Australian Immunisation Register, and they're fully vaccinated against hepatitis B. So for Salima, you need to find out if she has chronic hepatitis B. So you write query chronic hepatitis B on the form, ask for surface antigen, core antibody, and surface antibody. So Salima also has chronic hepatitis B. So she's surface antigen positive and core antibody positive. So she also needs a workup for disease phase and co-infection, just as you've just done for Mahmoud. The children are born in Australia. As you said, they're fully vaccinated. So their mum has chronic hepatitis infection. And she doesn't have any records of being screened during pregnancy, and the children were born in another state, so you can't access those records. So you need to also see if they have chronic hepatitis B, so the same 3 tests are ordered. And here, very fortunately, they come back as immune to hepatitis B. So they've got no core antibodies, so they've never been exposed to the virus, but they've got surface antibody above 10 international units per mil, so they're immune through vaccination. So the preventive interventions for those children have been successful, so they don't need any further action. They're protected against hepatitis B. Okay, so assessing Salima, same test that we ordered for Mahmoud. So she's also, she's E antigen positive. Her DNA is high, 2 million international units per mil, and her ALT is elevated. So Salima is in immune clearance phase, the second phase. So she needs to be referred. Her other assessment is fine, so full blood count fine, clotting, fetal protein. She's also susceptible to hepatitis A. So you recommend that she's vaccinated, and that can be started straight away. Explain to her about hepatitis B transmission and the natural history. Discuss the importance of chronic hepatitis B infection for any future pregnancies. Explain she's in immune clearance phase, so different to her husband, it's important that she does see a specialist and be assessed for hepatitis B treatment. And let her know that she might be started on oral antivirals. But it's also important for her to have the other liver health messages that you're giving, and check if there's any other contacts that may need screening, because clearly in this family there is a risk of hepatitis B. So maybe siblings, other sexual partners. So it's important to explore all that. Okay. So in New South Wales, we fund adult hepatitis B vaccine for high-risk groups. So any Aboriginal people, household and sexual contacts of acute and chronic hepatitis B, immunosuppressed people, people with HIV or hepatitis C, men who have sex with men, injecting drug users, sex workers, and clients of sexual health clinics are all eligible for free hepatitis B vaccine course. There was a restriction earlier this year and last year because of the international shortage, but the supplies are now replenished. So you can now order it via the online system, just with all the other vaccine orders that you put in. But please just use it for eligible patients. It's not to be used for travel vaccine. And we've got Endrix B at the moment. And the routine schedule is 3 doses at 0, 1 and 6 months apart. If there's longer intervals, there's no need to repeat a dose. And please report all doses to the immunisation register so that others that see your patients can know that they're vaccinated. I saw a question there about the hepatitis A vaccine and eligibility. So it's not offered free, but it might be rebatable on private health insurance. The children don't need to have hepatitis A vaccine because we're only giving hepatitis A vaccine to their parents because of the risk of co-infection of hepatitis B and hepatitis A, and because the children are protected against hepatitis B, that co-infection risk doesn't exist for them. Any other questions at this stage, Tim?
Yes, so there's quite a few come through. Someone was asking about detailed information about herbal medicines to avoid, if there's any source of information for that.
Yeah, and I'm having a mental block. Maybe you can help me, Tim. There's some real classics there. Sorry.
Yeah, not off the top of my head, but I can do some quick Googling and we'll get the information back to you. I think you're right that there's a whole range of different medications. Quite a lot of them do have interactions, and quite of them are can be upregulators of cytochrome enzymes in liver and have particular liver effects. I think often it's good to be cautious.
Yeah.
So we've got some people answering St John's wort and ginkgo biloba as being particular examples, and they're widely used by people.
Yeah.
So certainly the common ones we have to be careful of.
Yeah.
We've got questions about fibroscans and HEPA scores. About the value of those. A fibroscan gives a measure of the stiffness of liver tissue and is an indicator of cirrhosis, as I understand it.
That's right. So that would be something that would probably be progressed to if the APRI score is above 1. If it's by having a low cutoff for the APRI score, it's actually quite a sensitive test. So while fibroscans are becoming more accessible, really if patients have an APRI score of less than 1, there's no need to progress to a fibroscan. But if your patients do get referred to the liver clinic because of other factors, it will undoubtedly be done there.
Yeah. And someone's asking, does the APRI score need to be repeated and monitored? I suspect yes, because the ALT and AST and platelet score can all change.
That's right. So those tests should be ordered at the routine, at least 12 monthly monitoring.
Yeah. Answered that one. Does antiviral treatment need to be ceased in a future pregnancy? I think from what you're saying earlier, that may not be the case.
Yeah, usually not. It would usually be continued, but once again, the obstetrician and the hepatologist would need to work together to look at the individual circumstances.
Yeah, we've had a few questions about the booster vaccines of further hepatitis B vaccine. The immunisation handbook is pretty good on the decision making about immunity after the vaccines and whether to give boosters and how many to give. So
and it's important. Yeah, so if you're testing sometime after the course and it's less than 10, then you give the one booster test again. And if it's still low, then complete that second course. And if it's still negative after that, then it's important to exclude chronic hepatitis B infection. That can be a cause of non-response. but 2 courses if they've still not responded by that stage and they don't have chronic infection, they're a non-responder and need to take precautions if they are exposed.
Yeah. And there's a question there, after childhood vaccination for the boost, if an adult completed 3 doses of Hep B vaccine during childhood, hepatitis B surface antigen negative, core antibody negative, and anti-HB surface antigen is between 10 to 100, does he need hepatitis B booster? And I think it's over 10, then they're immune, aren't they?
Yeah, they're immune.
So they wouldn't need a booster. How long is hepatitis B positive blood infective outside the body?
Yeah, a long time. It's very persistent, and that's one reason it's a real risk for dialysis patients, for example. So probably about a week. Yeah, so it can live on tourniquets and all kinds of things. It's which is a real risk in health settings.
Yeah, and quite a few questions coming through there. There's a question about resources in other languages. You showed the posters initially for the campaign.
Yeah.
Are there also patient information leaflets in other languages as well?
Yes, there are, and I'm happy to send the link through to that later.
Lovely, thank you very much. Someone commenting about the vaccines being free in hepatitis C. I think you went through the New South Wales free vaccination schedule where it's hepatitis B for those groups on screen at the moment, but not hepatitis A.
Mm-hmm. That's right. And there's a question there about Twinrix in the past was 2 dose. I mean, that's only giving 2 doses of Twinrix will just give immunity to hepatitis A. To complete the hepatitis B dose, you do need to have a third dose.
Yeah.
And if that patient his surface antibodies 44, well, for prolonged immunity, a third dose of hepatitis B vaccine is recommended.
Yeah. Someone's asking about the Victorian schedule of hepatitis B. I don't know that off the top of my head. I don't know if you do. That's worth consulting the Victorian Department of Health websites. I think they'll have information on that, I would imagine.
I don't know what they offer free there. That was very generous.
Yeah.
All right.
Yeah, absolutely.
I'll just move on to this last slide, which is resources. Now, look, I've looked at all the health pathways for hepatitis B, and by and large, they're excellent. And in fact, they really take you through step by step what we've talked about tonight: who's at risk, assessing disease phase, monitoring. So I think that would be, I'd really recommend that you all use your health pathways to guide you through this. And the other thing there is there's usually a link to your local liver clinic referrals. So I think they're very handy. The other thing, and this is a resource that's in the handouts tonight, so there's a link there to it, you can download it, is from the ASHM, the Australian Society of HIV, Viral Hepatitis and Sexual Health Medicine. It's just a 2-pager that is probably useful to print out and really just summarises exactly what we've talked about tonight, how to interpret the tests, what tests to do for monitoring, etc. I think it's an excellent summary. But ASHM also have other useful things. So if you had a lot of patients with hepatitis B and wanted to become a prescriber, they offer the S100 prescriber courses. And there's other useful things there. They often have face-to-face training, more online training, and the national testing policies and so forth. So I think that's a really good website to have a look at. Okay, well, Tim?
Yeah, so these are our learning outcomes. So we've reached the end, it's 8:30. So by now we should be able to describe methods to identify our patients with hepatitis B, and those are all in the ASHM decision-making guide as well. So do download that. Understand the essential role of general practice in managing chronic hepatitis B. describe the way we do contact management, recount the triggers for specialist referral, and access the available hepatitis B resources and education tools. Thank you very much for your participation and all the questions that you sent in as well. That's fantastic.
Yeah.
Thank you very much, Vicky, for taking us through all that. And thank you very much, Sammy, for hosting us tonight.
That's great. Thanks, Tim, and thanks, Vicky, again. And also thank you to everybody online for joining us. We really hope you enjoyed it and enjoy the rest of your evening.